So first off, could you just explain your recent study of post-surgery opioid prescribing guidelines?
Yeah, absolutely. So we actually initially started this work in 2015, trying to better understand opioid prescribing habits, and because we obviously, we're learning more and more about the opioid epidemic in our country, and wanted to see how we were contributing to that. And so with that, we did a large retrospective study in 2016 to identify kind of opioid prescribing patterns, and really we kind of helped kind of figure out there that we not only were both over-prescribing, but we also just were not very accurately prescribing how many opioids we needed, meaning there was a lot of variation in how much we were prescribing. And once we kind of figured that out, that kind of set the foundation for, not only is there a national problem, but that there is a problem in surgery in terms of how many opioids we were prescribing, and we were contributing to this epidemic. And kind of that's, brought a lot of motivation to help try to improve upon this and reduce how much we were prescribing. So then with that, we developed opioid prescribing guidelines, and that took a lot of work because we wanted to not just kind of write blanket statements of how much to prescribe. We wanted to make sure that, if we were going to prescribe less, we wanted to make sure we're doing it in an evidence-based manner, and making sure that, patients are very different and patient surgeries are very different. We want to make sure that patients receive the right amount of opioids based on, their unique patient characteristics, and also their unique surgery, which can vary in terms of, the severity and the pain associated with it. So we did a large prospective study to try to identify how many opioids people really needed and how many were being kind of prescribed and then not used versus taken, and also kind of figure out some additional information about what they were doing with the opioids. And with that, we found that obviously we could prescribe a lot less, but also help really identify how many people needed. And then we rolled out guidelines across Mayo to help surgeons and physicians figure out how many opioids to prescribe. And obviously our goal was to prescribe a lot less opioids, but our goal was really just to prescribe the right amount and make sure we're not over prescribing, and still while balancing kind of pain control. And then as a result of that, we obviously wanted to follow up on that to make sure we were doing that successfully. And we knew we were prescribing a lot less, and we knew the majority of patients were overall still very happy with their pain control. But we then did this follow-up study that I'm presenting at the American College of Surgeons, where we wanted to look really into the patient-reported outcomes to better understand, are we really meeting the needs of the patients in terms of their post-op pain control? And so with that, what we found was that the vast majority of patients overall felt they'd received an adequate amount of pain control, and that they were overall either very or somewhat satisfied with their post-discharge pain control after surgery. And that was good. That's what we wanted. We showed that we were able to reduce opioid prescribing by well over 50%. We had, thousands of less pills in our community, and we were giving people the right amount with these guidelines. But then one of the kind of small findings we also saw is there maybe is a small subset of patients, and that was present before the new guidelines as well, but this number increased a little bit in terms of the numbers of patients that were dissatisfied with their pain control after discharge. And that correlated with patients who felt like maybe they had not gotten enough opioids. So that might be because we haven't set the right expectation for patients, but it could also be because they're not having their pain well controlled after discharge. And so our goal now moving forward is to identify these patients before they go home, to make sure that we're educating them appropriately on kind of post-discharge expectations. And then in some situations, maybe emphasizing non-opioid based pain control methods more, although what we found is actually majority of patients are taking non-opioid based pain medications before and after the guidelines. And then lastly, maybe in some cases we do need to alter how we prescribe in some patients, while obviously balancing that with that we don't want to swing the pendulum the other way either. And so those are kind of the major findings of this study that was really more to kind of ensure that changes we had made, which a lot of other institutions had made as well in the last couple of years, were in the best interest of the patients, and then also how to move forward from this. Because I think making sure that 90% of patients have a good experience is great, but we need to get to 100%, and that's kind of what the goal of this study is.
So what would you say is most important for practicing oncologists to take away from the study?
Yeah, I think the most important thing is that we can reduce how much we're prescribing, and still the vast majority of patients are going to have adequately controlled pain after surgery. And that's the most important thing by far, because we do know that we were overprescribing, and that is putting patients at risk and their families at risk and their communities at risk. So the number one takeaway is that these opioid prescribing guidelines, either using ours or using in the ones many institutions have developed their own, they do work and they are safe, and patients overall still have their pain adequately controlled, which is very important in all patients, but particularly cancer patients, which are included in our study. But that also this needs to be individualized. And it's not, if there's a patient that's having uncontrolled pain, that happens. That's not because they're narcotic seeking or opioid seeking. It is that there's a small subset where guidelines don't work necessarily perfectly. And I think that's the point of being a physician and a clinician is, you have to individualize the needs of the patient, and you use guidelines to improve practice and to meet the needs of the majority of patients. And then you adjust based on individual patients. And I think, how to incorporate them into guidelines is tricky, but I think most clinicians know how to kind of address each patient and can do that if they're aware of that group of patients.
So for those who may be unaware, why is post-surgery pain management so important?
Yeah, I think it's important for one, because surgery is an inherently scary experience for patients, and it is inherently painful. It is a trauma. There is no way around it. We do a lot of minimally invasive surgery. We use a lot of multimodal pain control. We do a lot of things to make surgery less painful. And the majority of patients have a very good experience. If you ask patients before surgery, their number one fear is usually pain. Actually more than the surgery itself and the risk of complications. Patients fear pain. But after surgery, most patients actually are very satisfied. Like 93% are satisfied after discharge, even with their pain control. So in reality, patients do actually very well with surgery, and their pain is very well controlled across the board. So I think that's a problem that we need to reassure patients better about, that they need to expect pain, but overall, we're not going to leave them in pain. And I think that's kind of where having data to support that and not just experience can help. Because, especially in the situation of cancer, we do want to make sure we're managing patients' symptoms appropriately. But also, overprescribing, which historically in cancer, we've often overprescribed opioids because we're so worried about patients having, uncontrolled cancer pain, which is very reasonable. Nobody wants to leave somebody with cancer in pain. But what we're learning is that overprescribing opioids is not the solution to that. That just develops tolerance and dependence, and that doesn't improve quality of life. So we need to actually address the pain and fix the pain and use opioids when necessary, but otherwise minimize that to the minimal amount needed. Because in general, most patients don't want to be on opioids, right? They don't want to have pain, but they also don't want to be on opioids. That's not the best way to get rid of pain.
So in your opinion, how should doctors go out talking to their patients about opioids and the risks involved with being prescribed opioids?
Yeah. I think it really depends on the situation you're talking about. I think, we know that opioids have significant risk, and even a short course of opioids does have a risk of dependence and abuse and misuse. But in general, the majority of patients who go on to kind of long-term dependence or abuse, this is not a short-term opioid use. This is not because they had a minor procedure or even a major procedure where they used opioids for a few days. Most of those patients do recover. Now, there is a small but real subset that do go into chronic opioid use, and that we need to prevent because that means they have a complication from their surgery. But most patients do relatively well. So we need to both counsel them that opioids have very real risks, but there are situations where we can use them safely if we watch them closely and get them off opioids. So I think it's finding the balance between the two, and certainly not using them if we don't have to, though. And I think patients are on board with that. And as long as we actually have conversation with the patient and try to find that balance for them. And sometimes that balance is opioids, and sometimes that balance is non-opioid based pain medications. We can manage, patients' pain well, including those with cancer.
So though there are risks to prescribing opioids, obviously, as you said, there are plenty of benefits as well. So in addition to what was outlined in the study, what do you think needs to change so that patients can safely continue to be prescribed opioids?
I think the one thing through all this, and we've obviously been a big proponent of guidelines and minimizing how many opioids we're prescribing. But the one thing that we've always tried to emphasize is there is not a one-size-fits-all guideline. And national recommendations are great, but guidelines need to be evidence-based and they need to be flexible because every patient is different. And and you need to be able to alter your prescribing to meet the needs of the patient. And sometimes that means more and sometimes that means less. But what really worried me is when, things like insurance companies and state and federal, regulatory agencies start providing concrete limitations on what can be prescribed. And I think that needs to be done carefully and safely and using evidence and not just reactionary measures, because I think we can, get control of the opioid epidemic without making, wide-reaching kind of laws that limit what we prescribe. And I think if physicians and clinicians in general are willing to be engaged in this process and use evidence-based guidelines like the ones we use in this study, we've shown that we can reduce how much we're prescribing, and I think we can move things in the right direction without kind of absolute regulation to limit. Because I think it does need to be taken on a patient-by-patient level, especially in the setting of cancer, where it's an inherently for some patients painful experience, and we need to make sure we do manage that pain. But we, with the caveat, as we have for a long time, overprescribed because it was a crutch. It was an easy way to manage pain. And I think in 2020, just prescribing narcotics to manage pain or pain medications is not a solution. We need to address why patients are in pain and sort that out without ideally opioids too, though.
So that's all I had for you. Is there anything that I didn't ask that you think is worth mentioning in this space?
No, I mean, I think, obviously this is we did a large study initially, and our large studies are all published online and available to you. This is a smaller study of a single center. So we're, looking at patient-reported outcomes. It's a fairly large study by that sense, but still an overall small single-center study. So, I think we need more research to try to identify, is this a real group of patients that really are in pain, or is this driven by other factors like procedural variation before we start changing how we prescribe. But this is a first step for us in terms of figuring out what additional research we need to do, and if this really is a group of patients we need to change what we're doing based on.